And good evening. Hi, Xavier. Thank you so much for joining me on the Amelio podcast. Could you share with our audience a little bit about your background and your passion in chronic pain management?
Yes, thank you so much, Kathy. It's good to see you. Thank you for having me on. So for those who don't know me, my name is Dr. Xavier Jimenez. Some people call me Dr. X. The Javier is spelled with an X, so it's a little confusing. I'm basically I'm a physician in the New York area that specializes in about 3 areas: psychiatry, pain medicine, and addiction medicine. And the way that I ended up with those specializations is still a surprise to me, a pleasant one. I love what I do, but I did not know that I'd be doing this. I'm a Cuban American kid from Miami, Florida, and was always very restless and interested in philosophy and ethics and topics of that sort. But I decided I wanted to go into medicine when one of my aunts was a physician. She's now retired, and she influenced me. And when I was in medicine, I was fascinated by every topic, particularly surgery and physiology and all of these topics. But I really fell in love with psychiatry. I thought, the mind as the next frontier was just so fascinating. So I specialized, after becoming a physician, I specialized in psychiatry, but I never really felt comfortable being only quote unquote a psychiatrist. I really kept one foot in the medical and surgical space. And as a result, I did some extra training in what's called consultation psychiatry or medical psychiatry. My training was at the University of Pittsburgh Medical Center for psychiatry, and then after went to the Harvard system and Mass General for a year to specialize in medical settings, psychiatry in medical settings, or consultation liaison psychiatry. That's actually the first place I became interested in pain management. It was accidental, I think. I was actually in a burns unit, a trauma and burns unit. Horrible stories of individuals with severe injuries, requiring skin grafts, various interventions, surgical interventions. And my mentor, who was a psychiatrist himself, said, "Don't be afraid of managing and helping people with pain." So that was my introduction. After years of specializing in psychiatry, go back to the basics of medicine and help individuals who are in pain. And from there on, I never looked back. I've only worked as a psychiatrist in medical settings. After that training, I went to the Cleveland Clinic and was there for about 8 years and specialized in a number of areas, medical areas with psychiatric dimensions. So for instance, I worked in an epilepsy monitoring unit for a while. I worked with rheumatology, with orthopedics, with anesthesia, neurology. And the area that I spent the most time in, which is germane to today's discussion, was chronic pain. I had a mentor who was running a program there at the Cleveland Clinic called the Chronic Pain Rehabilitation Program. This was a multidisciplinary entity where we had doctors, nurses, psychologists, physical therapists, occupational therapists, music therapists, everyone working together in a very dynamic way to help individuals with chronic pain that was very lasting and disabling. And in that space, I became the medical director. I became board certified in pain medicine. And I also became very interested in sort of related topic of addiction medicine and became board certified in that as well. But all of this was somewhat accidental. I went into medicine really thinking about what every kid thinks about, right? Let me fix a broken bone. Let me transplant an organ, save a life, that kind of stuff, right? The flashy stuff. And then I realized, actually, when you're in medicine, you see enormous suffering and you see enormous pain, enormous chaos. And I wanted to help bridge some of those gaps. So that's what got me eventually to where I am. I'm currently working for Northwell, which is a large health system in and around New York City. And I continue to see individuals who have chronic pain, mental health concerns, addiction, or some combination of those, both in the hospital and in clinic. I have a clinic also where I see individuals in the ambulatory space. And I continue to strategize with the rest of Northwell, a growing health system, to deliver integrated care models so that we can really fill in these gaps that are inadvertently created by our massive healthcare systems. That's kind of how I got here.
Wow, that's an amazing journey. And it's really interesting that you sort of fell into chronic pain management. I can really relate to this. I myself came from acute pain management background, a role in nursing, which led me to pain management, and then psychology, which is, very similar journey, isn't it? And it's really interesting where I was working in, trauma and acute pain and ICU and anesthetics, recovery, those sorts of areas. And then also working in a multidisciplinary pain clinic like yourself. And we could actually see that, the people would come from that acute phase and then into the chronic pain clinic. And you think, wow, I've just seen this from beginning to end, and I can see where these cracks are. That's just phenomenal that you're talking about that. Can you tell me your thoughts on the links between mental ill health and mental wellness and chronic pain? I know it's we often talk about mental health, but I think we're missing the point here. We're actually missing the fact that it's mental ill health and chronic pain.
It's a great topic, and we can go on these relationships for hours. The relationship between mental health or ill health and chronic pain is rich. It's bidirectional in the sense that each domain influences the other, and is what is perpetually fascinating in my work. I will start with a disclaimer, because some individuals who have chronic pain will react to somebody from mental health, like a psychiatrist, psychologist, therapist, trying to, quote, help them with their pain. And some individuals react to that poorly and think this is a purely medical issue. There's no space for those kinds of discussions. I obviously disagree, especially in chronic disabling pain. But to get to your point, when we have somebody who is especially exhausted conventional medical interventions, hasn't responded to them, continues to languish, is disabled by their chronic pain, that's really where we have to incorporate a broader, what's called biopsychosocial approach, which includes psychological dimensions. It's not the only factor. We have to continue to balance the biological and the social too, but the psychological is part of it. And I think, to answer your question more generally, the relationship has a lot to do with what we call the pain experience. I think most people really fixate on, I have pain or I have chronic pain, and yet don't really get as curious as maybe they need to be about their pain experience. What does that even mean? That means how somebody in totality is experiencing their pain, not just that it hurts. The physical component of it is very important, sometimes the most important part. But in other situations, there's the physical component, the sensation of pain, and additional layers of experience. And those layers of experience can be psychological. They can be anger, sadness, fear, panic, depression, all sorts of experiences that come with and around, related to, etc., the pain. That pain experience is squarely a psychological phenomenon. And that's where you start to see that individuals with mental ill health versus mental health issues vary widely in their pain experience. If you ran an experiment or even just did a population study on everyone who has very similar or identical medical injuries, diseases, concerns, and then plot them out over time and see how many of them even have chronic pain to start with. Secondly, of those with chronic pain, what is their degree of disability and pain experience? You will see variability. You will see differences, which points at individual, again, pain experience. So to get back to your point and how you phrased it, mental health, mental ill health is huge in ascribing some variability to how individuals navigate their pain. And of course, we have lots of research to suggest that more specifically. There's the granular stuff about, well, if somebody, for instance, has a very negative pain experience with fear-based cognitive patterns, catastrophizing, which is worst case scenario thinking, or other distortions, they're going to have poorer prognoses. They're going to cycle into disability at much greater rates than somebody who doesn't have that thinking pattern. So that's a clear example that has been studied many times. On the flip side, alternatively, we have positive thinking patterns like increased self-efficacy or optimism, a sense of agency and mastery. These kinds of tendencies tend to portend very, very well for the individual with chronic pain, and rarely will they have significant crippling disability. So those are just two micro examples of what I think you're referring to in terms of mental health or mental ill health impacting the total chronic pain experience.
Yeah, this is exactly what we found in our online chronic pain program. And this is why we use behavioural scores and combine it with wearable data so that we can actually see that impact of these, sleep, mood, behaviours and resilience on how they're actually coping with their chronic pain. How do you think resilience and chronic pain are intertwined?
Yeah, that's a great question. Firstly, I want to say that you guys in Amelio Health are ahead of the curve from what I can tell, and even thinking about these dimensions of chronic pain and measuring them and being data driven in that regard. So I commend you for that. Most of healthcare really isn't set up for that, unfortunately. As far as resilience is really the counterpoint to vulnerability, right? And individuals with high default resilience are going to meet challenges very differently than somebody with very low resilience or high vulnerability. And so resilience is a very protective kind of element. Individuals with a lot of support, a lot of front loading of knowledge and health literacy, a lot of incentives to be well for. These individuals have a resiliency package, if you will, that will buffer against severe disabling effects of chronic pain. There are other psychological factors too, not just the environmental ones that I just listed, that would be incorporated into resilience. So this is the other side. These are the individuals we don't see in our chronic pain clinics because they're thriving despite horrible diseases, injuries, surgeries, and other pain conditions. But I will say the good news about resiliency is that it can be built up. It's not a static phenomenon. Individuals, even with some vulnerabilities, can develop quite a bit of resiliency. It's a dynamic issue that can be manipulated, if you will, by the individual in healthcare, and we can team up to actually bolster that. Like a muscle that has been weakened or underdeveloped, it can be developed. And that's, I think, an important optimistic take on this. It's not about only focusing on individuals and their vulnerabilities, their weaknesses. It's about also boosting up that resilience. And by the way, I'll just add this. I don't think of resiliency as simply an attitudinal or psychological phenomenon. Individuals tend to think it's soft and it's all about optimism. It's actually also about neurobiology. Individuals can beef up, if you will, their resilience physically too, through conditioning and being able to withstand more. And furthermore, even at the level of analgesia, the term for pain control, we see that individuals who, for instance, now I'm going to get very technical, beef up their descending pain pathways and their inbuilt endogenous painkillers, their endorphins, all of that. When they beef that up and condition that up, they also develop a form of resilience that is neurobiological, that arguably is medical. So there are medical and psychobehavioral and social elements that can be woven into the enhancement of resiliency. I think it's a critical target for us in chronic pain management.
Yeah, what we've found is that we've now got a marker for it. So looking at the wearable device, we can now see that difference in the heart rate variability between the sympathetic and the parasympathetic nervous systems. And that is our marker now for people actually gaining resilience. And it's really, really powerful when we can actually share this information with the person that's going through our pain program. Sorry. And we can see, they can start to see, I have the worst night's sleep. I really didn't get any sleep. I feel like crap. And, well, that's pretty obvious. I can see it on your wearable. You literally had 300 minutes of sleep, and then it's only light sleep. You didn't get any REM or deep sleep. So any wonder, you're feeling pretty bad. And if you take a look now at your heart rate variability, you can actually see that you're not as resilient today. So, it's a very real biofeedback for them, and they go, oh, that's why I can't cope with the kids screaming and being annoying to each other, and I just snap and I take it out on them, and then they feel guilty, and it's just this sort of cycle, isn't it? So it's really, really powerful information, I think, is being able to give that now back to the individuals and be able to say, this is why this is happening. This is, you're not a nutter. And the fact that you're a psychiatrist, I think, is really pertinent to that, because, that's what people think the doctors are saying to them. I'll send you to a psychiatrist because we actually think you're a nutter. And they actually start to think they are a nutter themselves, that they're going out of their mind. And I guess opioids play a really big role in this, these feelings of, not coping, and the levels of fatigue, the interference in sleep, and then exacerbating this problem with resilience. How do you see opioids play a role in this particular mix?
Yeah, it's a great and loaded, controversial topic. Opioids sadly claim the lives of many, and it's been a huge issue in the United States in particular. I did want to say briefly that I love the biofeedback example you were offering about our sympathetic nervous system. It's just another physical dimension to resiliency that you can modify and enhance and empower the individual to feel more in control. This is all about individuals managing their pain as opposed to the pain managing them. And back to opioids, opioids are important analgesics for certain situations. They are needed for acute pain, for terrible, medical processes at times. If you recall, my introduction into pain management was acute pain management with burns and trauma and the perioperative space. So clearly opioids have a role. The mistake that I think we made with our approach to chronic pain is just extrapolating lessons from acute pain onto something called chronic pain that is vastly different. Chronic pain, as defined 3 to 6 months beyond its original acute pain progenitor is a very different phenomenon. I think opioids there have a diminishing role. It's not a zero role. There are some individuals, although very rarely, that may need opioids. But time and time again, we have learned that there are more cons than pros to continuing opioids in chronic pain. They may restore function in a few individuals, but by and large, they contribute to a host of other problems. And I won't even focus on the highly publicized ones like addiction or overdoses. Those are extreme examples, even though they're very important. Even within pain management, opioids actually are known to cause, paradoxically, worse pain through
Yeah.
opioid-induced hyperalgesia or upregulation, if you will, strengthening of pain pathways. And so paradoxically, this tool that we have all hoped would be, very effective in chronic pain can be backfiring in a number of individuals. And I see time and time again that, either diminishing or detoxing, eliminating the opioids safely and judiciously can be a huge component of the recovery process for individuals with chronic pain. Not always the only one, but a big part of it. In that space, we have to, of course, educate patients as to why this is, necessary or important to think about. We also educate going back to the descending pain pathway and our own endogenous pain relieving pathways. We have to educate about how that pathway has been weakened actually by chronic opioids. If you're taking opioids from the outside, your own endorphins are going to take a backseat. Let's get those endogenous endorphins back online. So I talk about all of this neurobiology to make it clear this is a medical intervention. This isn't about, being afraid of the government and policy and preventing addiction. It's more about helping somebody's actual pain condition. And so to answer your question, I think opioids have a diminishing role in chronic pain, next to or near zero. But I don't want to say zero. There are some outliers. And so we need to think about everything else that can be entertained, and not just other medications, of course. There are other strategies through physical, psychological rehabilitation, and so on and so forth.
Wow, that's amazing. You recently shared a video on YouTube and Instagram. I love your videos, and keep going, Dr. X. It's great. About helping people discontinue opioids, utilizing a biopsychosocial lens. Can you enlighten us about this approach? I know that it's very similar to what we're looking at as well, and I'm really, really fascinated to see, how you bring that about.
Sure, thank you. I encourage anyone who's interested to see the videos, but essentially, as I just alluded to, stopping chronic opioids in chronic pain is not a simple task. It requires some careful consideration of all of the factors involved. What I alluded to earlier in terms of pain experience, other thought processes, comorbid or accompanying conditions. So it needs to be taken very seriously and carefully. There are no shortcuts, they say famously, with opioid discontinuation. And what I say as a very first thing to individuals who are grappling with this question, should I continue, should I not, is I say to them, you've been on chronic opioids for 4 years, 10 years, 15 years, whatever the duration is the question I pose to them is, would you be willing to entertain something much shorter than that, a couple of months, maybe even less, as a process to get off of these opioids? It took a long time to get us here. Would you be open to something briefer than 4 years, 10 years, 8 years? And most patients, agree with that. And to get back to the biopsychosocial meat of the matter, it really is attending to the biological, the psychological, and the social all at once. It's a balancing act, and we have to hold all of these at once. So the biological part would be, of course, safely discontinuing the medications over time, thinking about alternative medications, either transiently, temporarily, or long-term, that have less effects than opioids, and helping manage that pain appropriately biologically, if you will. And by the way, I've also trained in interventionals, anesthesia, nerve blocks, all of that. So I also incorporate that when the time is right for that. Psychologically, there's quite a bit of work that needs to be done around the individual's, again, pain experience, their fear of discontinuing opioids, their fear of pain returning. These variables cannot be ignored. You have to anticipate them and say they're going to come up, but also educate individuals in ways that they're prepared. For instance, one important dimension for individuals to think about psychologically is they need to understand that sometimes when something hurts, it doesn't actually mean that it is harming them. That hurt and harm distinction is critical So that's a very important psychological space to reside in for a moment, so that individuals don't get paralyzed by the fear of something harming them. And remember, harm has connotations to trauma, injustice, other things that scare really anyone, but in particular individuals who might have been harmed before. So hurt alone, although it's unpleasant, doesn't equate to harm. So that's, the beginning, if you will, or one major component of understanding the psychology of coming off of opioids and the rebound pain and withdrawal and things of that sort. And then the social part is very important too. Individuals really need to feel supported through this, not just through our healthcare connections, but family, community, friends. They may have developed all sorts of social patterns over the years that are now being challenged and disentangled. Their life may have become quite small due to chronic pain and chronic pain disability. And now instead, we're actually inviting individuals to get out in the world and be more active and make social connections. So these are just a few examples of the biological, psychological, and social elements that are needed for individuals that are going to come off of chronic opioids. But of course, each case is individual. Some may need different medications. Some may need cognitive behavioral therapy, motivational interviewing, things of that sort in the psychological bucket. And then socially, of course, family interventions and social interventions.
Yeah, it really needs to be tailored to the individual, doesn't it?
Customization.
Yeah, and I guess too, they've got to start to gain confidence that they can actually start to reduce these medications, and that's something that we do, I think, quite well, in that we find a medication, because they're usually on multiple different medications and usually very high doses. What we've found is that if you can find a medication that they might have missed at some time and found that it didn't really make much difference, that's what we tend to start with. And it might be something like the gabapentinoids, or even anti-inflammatories. So we know that anti-inflammatories aren't very effective for chronic pain, because there's really no tissue inflammation at that time. And so what we get them to do is to start reducing one slowly that hasn't been very effective for them, and see that it's not really making much difference as they're going off. And they start to get quite confident of being able to do that, and then they can work on the more difficult medications afterwards with that support around them that you were just talking about. I think this really leads straight into my next question. And that is, emotional trauma. Does this really set our nervous systems up for chronic pain, especially in childhood, and, this sort of physical and emotional trauma? The mind and the body, we just can't separate.
Yeah, I love this topic. It's a complex one, and yet not at the same time, because you're right, the mind and the body can't be separated. The short answer to that question, my visceral reaction, is not exactly, but sort of.
Yeah.
So clear as mud, right?
Yeah.
Emotional or physical trauma, early development, childhood, etc., these adversities that we sometimes refer to as adverse childhood experiences, etc., absolutely shape the nervous system. And by that I mean the central nervous system primes the central nervous system to be on high alert. It shapes our autonomic nervous system, our fight-flight pathways. Absolutely. This has been shown numerous times, and there are downstream health consequences from this. And this is where the causing of chronic pain is where it gets complex. There are some individuals who have had adverse childhood experiences, trauma, etc., and don't develop chronic pain. And then there are others who have quite a bit of that, and it seems to be an important ingredient in the development of chronic pain. The chronification of pain is a fascinating area of study. When we crack that nut, if you will, and figure that out, then we'll really be able to prevent, chronic pain, hopefully. But what we have seen is sadly, enormous rates of developmental trauma and childhood adverse experiences in those with severe chronic disabling pain. It's not the only thing or the only factor involved, but it certainly sets up the central nervous system to be on high alert, to recover poorly or not at all, sometimes to stimuli, and to have fight or flight reactions that just do not help with the ultimate pain experience we were describing earlier. So somebody without trauma, somebody with trauma, they both go through the same car accident, have whiplash, let's say, or same surgery. The one with trauma is going to be in heightened sense of vigilance and have downstream problems from that. The other one, while it was unpleasant as well, may not have that experience, and that alone can make the difference in terms of recovery.
Yeah. And we've seen that, published over and over again. And I think Professor Michael Sullivan from Canada has published on this quite a lot, in particular the learned catastrophizing behaviours that people develop when they've been through these sorts of trauma, but also the way that they've, maybe grown up in their social environment as well. So those learned behaviours of acopic responses, but also to perceived injustice is something that he talks about as well. And that's something that we measure in our program to just see how much of the epistemic injustice plays a role in this, continuation of the heightened sensitivity of the nervous system. Wow, it gets very deep, doesn't it? It's just incredible. And, this has just been a truly inspirational conversation. And thank you so much, Xavier, or Dr. X. I think that's a really, really good analogy. And then I hope you will join us again for further insight into chronic pain management. Thank you so much for talking with us today.
Thank you so much. Each of these topics can go on for an hour, and it's a delight. Thank you so much, Kathy.
I think we'll be joining forces again and really digging deep into some of these other topics. I think there's so much more that we can talk about that is valuable for our participants that are going through both of our programs.
Sign me up. We're allies, and I love what you guys are doing with Amelio Health. It's very data driven. It's very powerful. Again, you guys are on the cusp of something really fantastic and empowering individuals. And if this can help even one individual out there, then I've done my job.
Me too. Thank you so much.
Thank you.